Cool. All right, my name's John. I'm an RMO, work at Carlin, and the topic for my lecture is breast and endocrine. I don't have like too many cases or like interactive aspects on this because I used to hate when people pulled me up and I either didn't get any interaction or like I didn't enjoy getting asked myself. So basically just going to be talking through it. But if you want to interject at any point, ask any questions, then please feel free. These are the topics I've been asked to speak about today. So it's basically just benign and malignant breast disease, the same for thyroid disease, a little bit about hyperparathyroidism and adrenal tumors with a very specific surgical focus. So I'm not really going to be going through too many medical aspects of these conditions. I guess the things about endocrine as a specialty is that it's very different probably to a lot of the lectures you've had about other surgical specialties where they focus on a lot of acute presentations and emergency settings where you see patients. Breast endocrine is probably a narrower area of general surgery, but at the same time, it's an area that has a few niche things that if you haven't done a rotation in it, or even if you have, you might not have come across. But obviously the main things that are important in breast endo are breast lumps and particularly breast cancer, as well as thyroid lumps, which occur either in isolation, in goiters, or in the context of cervical lymphadenopathy. So we'll talk a little bit about breast disease first. The next couple of slides are a general approach to patients when they present with a breast symptom. So the two most common things that you're going to see patients complaining of either pain in the breast or of a breast lump that they've found on self-examination. So essentially pain in the breast can be either occurring with the menstrual cycle, which is called cyclical mastalgia, or it can be independent of it, which is non-cyclical. In general, pain that varies with the menstrual cycle is going to be physiological in nature because it's responding to hormones. So almost always is benign. But that which doesn't vary with the menstrual cycle is more likely to be due to an underlying pathology. And so you can consider referring to those patients. And I'll go through this in a bit more detail in a sec. Obviously, lumps in the body can be classified in so many different ways. In this particular table, it's classified based on how firm the lump is, because it's a relatively good guide in the breast that firmer lumps are more likely to be malignant, but at the same time still have a differential, which the ones that they've listed here are basically, so various aspects of fibrocystic change, which could be a fibroadenoma or more global fibrocystic change, fat necrosis, or non-infective inflammatory conditions, which could be stuff like duct ectasia or intraductal papillomas. The opposite end of the spectrum is things that are soft, which are usually either a lipoma, which is a benign fatty tumor, or a simple cyst. The trouble that you get into in private practice about whether or not to refer these patients is the middle condition where patient might have a background of fibrocystic change, so that the breast is very dense and glandular, and it's difficult to actually feel apart any area of that could be a malignant tumor. And that's where you kind of have to use your clinical history to risk stratify the patient, as well as monitor them over time. Because as we'll come to, fibrocystic disease basically should sort of progress with the normal development of the breast and then also regress with the involution of the breast. So anything that continues to enlarge when it should be going away is the warning sign. Other things are skin changes. So almost all skin changes in the breast are concerning for malignancy, or at least something that a surgeon needs to see. So they get referred, whether that's dimpling of the skin or tethering, the peau d'orange appearance. Redness can be a sign of mastitis or breast abscess, which needs to be drained, or of inflammatory breast cancer. And ulcerations, unfortunately, seen in cases of neglected breast cancer. And then nipple disorders, which there's not too many that are important for you guys to know about. Inversion of the nipple can occur spontaneously during puberty, but any changes to the nipple in adulthood are usually malignant, so they need to be investigated. Any rash around the nipple or areola area can very uncommonly be due to a dermatitis, but if it doesn't respond promptly to treatment for dermatitis, then you need to think about Paget's disease. Nipple discharge can be normal in a lot of circumstances if it's clear. Obviously, if it's milky, then it's either pregnancy or it's prolactin driven, which has multiple causes, but I'm not really going to go into the medical aspect of that today. Green discharge is characteristic of something called ducted ectasia, although there's a couple of differentials for that here. And bloodstained is usually only seen in either cancer or something called an intraductal papilloma. But either way, because it's a high chance of being malignant, it needs to be worked up and considered as such. So mastalgia, I'm just going to briefly go through each of the benign breast conditions and summarize the key points that you need to know and key treatment principles. And then we'll go through breast cancer a bit later. So mastalgia can be cyclical or non-cyclical, as I said. Cyclical tends to occur in younger women, and it's classically in the upper outer quadrant. It tends to occur worse just before the onset of menstruation, and once menstruation begins, tends to go away. But as it's usually due to a benign process, it doesn't need any specific workup or treatment. So reassurance, limiting caffeine can help. There is a compound within evening primrose oil, which can help. Basically, the mechanism is something related to fatty acid pathway and inflammation. And because it's hormonal in its etiology, there are hormonal therapies that can help as well. Non-cyclical mastalgia tends to occur in older people, but we need to rule out pathology in that group. Acute mastitis and other infective conditions. So mastitis should be divided into lactational, if it's in so breastfeeding population, or non-lactational. So lactational, the key things to remember is it's almost always due to staph, which is found in the baby's nasopharynx. The important thing is to continue milk expression because stasis is bad for infection everywhere in the body. They get treated with antibiotics, which is usually Fluclox because of its staph coverage. And you need to monitor for the development of an abscess. Don't think you need to know too much about the non-lactational mastitis. Smoking's a big risk factor for it, but otherwise there's nothing special about it. Breast abscesses present as you'd expect an abscess to in a superficial area anywhere in the body. It's treated in the same way. You want to get rid of all the pus, so they often require repeated aspirations with antibiotic coverage. And you aspirate to dryness until it basically stops giving you anything. If it starts to look ugly, then they get more extensive treatment, like incisional drainage or more extensive surgery. I've just got ductictasia in here because it's got some key like buzzword features that are present in MCQs sometimes. So it's usually in an older smoker. The pathophys is basically that there's dilated ducts, which causes stasis of the secretions and irritation. The green discharge and the slit-like retraction is like the key features in that. But because there's nipple change in an older women, you need to rule out malignancy. Benign breast lumps / lumpiness of the breast. So all of these kind of come, except for fat necrosis, under a broad heading of like Andes, which are aberrations of normal development and involution of the breast. So fibrocystic change is basically a broad lumpiness of the breast due to proliferation of glandular tissue, and it's often associated with cyclical mastalgia. So there's nothing specific that needs to be done about that, other than it can make it a little bit more difficult to detect masses. And you treat the mastalgia. Fibroadenoma is a differential for a breast lump, an isolated breast lump, and it's usually it's considered like a localized form of fibrocystic change. But the way it classically presents is in a young person, a smooth and small, so usually less than 2 or 3 centimeters size, mobile breast lump. So it's often called the breast mouse because it moves around a lot on your exam. It grows over about 12 months and then stops and even starts reducing in size after that. So in a young person, clinical exam is enough. in an older person, you want to make sure that it's not an unusual presentation of malignancy. And so you'd still refer them for the full triple tests and workup, including a biopsy. Breast cysts are also part of the spectrum of fibrocystic change. They tend to occur later on because cyst development is sort of part of the involution process of the breast. And in people that have multiple small cysts that coalesce, they can form into a sizable cyst that can be palpated. That's why it's in sort of older perimenopausal women. It can present in multiple ways. It can be firm, it can be soft, tends to be deep, obviously not as mobile as the fibroadenoma. Cysts have a characteristic appearance on ultrasound, so that can be very useful in the diagnostic pathway. To confirm that it's a benign cyst, you need to aspirate. So the radiologist will do that. They'll send off the fluid for cytology. And if it comes back, clear of cytology and it's just normal clear fluid and never comes back, you never have to worry about it. But indications that it might be malignant, or if it's bloodstained, obviously if there's positive cytology, or if it comes back. And fat necrosis is a thing that's commonly brought up as a differential for malignancy, but it's actually very rare. And the only time that I've ever seen it is in domestic violence cases. It presents in exactly the same way, or it can present in exactly the same way, the way that malignancy does. So that's why it needs to be treated as a possible malignant lesion. And we never really put too much stock on the fact that there's presence of trauma in the history, whether it's present or not, because usually in a lot of cases, trauma just brings a pre-existing lump to somebody's attention, rather than it being the inciting factor for the lesion. And vice versa, a lot of people might have a history of trauma that they don't recall on their history, and actually have fat necrosis. The final thing to talk about in benign disease is this case of duct papilloma, which is just, I brought it up because it can present with blood-stained discharge, even though it's a benign, in inverted commas, condition, and can present with a mass as well. So you still need to work it up as if it's a malignant lesion. But the nice thing is that if it comes back as a papilloma, you can get away with just resection of a duct or a small area of the breast rather than having to do a wide local excision or a mastectomy that you would do for malignancy. All right, that's the boring benign breast stuff. We're going to talk about breast cancer now. So the first thing I want to talk about is breast screening. There's not too much that I think you guys need to know about breast screening, and I certainly don't think you need to memorize like the risk stratification process and all the different changes that has in terms of how you screen, as well as all the detailed genetic aspects. But you definitely need to know what the current screening program is. And that's basically just a screening mammogram every 2 years between the ages of 50 to 74. But you can also access that program free of charge between the age of 40 and 50, but you're just not invited to it. So it's on an elective basis. The only thing I think you do need to know about stratifying higher risk groups is that we use like a scoring system for it. So it's literally an online calculator. An example of that would be the iPrevent tool on the Peter McCollum website. This is just an example of things that would put you in moderate or high risk category, but it used to be that this was how it was stratified. So like a moderate, for example, would be a primary relative that had young onset of breast cancer, or you had 2 relatives on the same side of the family. High risk is basically a family genetic mutation like a BRCA gene, or 3 primary relatives on the same side. So I'm not going to go through this in detail, but these are there for your perusal later, I guess. It's the summary of the recommendations for screening, as well as risk reducing treatment that we can use for the moderate and high risk groups. So this is the other aspect of breast disease. So there's kind of 2 streams that patients get referred to a breast endocrine service. It can either be through screening, or it's through the identification of a breast lump or any new breast symptom that needs to be worked up. So the triple test applies to patients that present with a breast problem. So it's different to the screening pathway. triple test consists of clinical assessment, so history and exam, which I'm not going to talk about too much more. But imaging and biopsy are the second and third components of that. So I thought I'd talk a little bit about imaging and biopsy in more detail, because it might not be something that you come across or understand why we do certain things, as opposed to history and exam, which are slightly more straightforward. So for imaging, we kind of base it on how old the patient is, what first test they get. So it's ultrasound as first line for people under 35, whereas people over 35 get mammogram as a diagnostic mammogram and an ultrasound. The reason is that mammography is less sensitive in patients under 35 because the breast tissue is more dense, so we can't see a breast lesion as easy on the dense tissue background. MRI is not used in the workup of a new breast symptom, at least not in a primary care setting. It's sometimes used once a tissue diagnosis is made in a specialist basis by the breast endocrine surgeon. And I'll talk a little bit about why, but basically lobular carcinoma can be bilateral and in multiple areas. So you want to sort of stratify exactly the extent of it. Same thing for DCIS. You want to see how much of the breast is involved, because that'll influence your treatment. It is Medicare rebatable now for high-risk patients to have like annual MRIs before the age of 50. And in implants, like if you've ever seen a mammogram with a breast implant, it basically just like covers the whole thing, so you can't see what's going on behind it. If you asked about biopsy, which type of biopsy to do, the answer is almost always core biopsy, unless it's a simple cyst. Like I said, like ultrasound is pretty good for determining if something's a simple cyst. So you can use it. So in that case, you're pretty confident it's just going to be, I just got to draw out some fluid to confirm that it's a cyst and send it off to check, for cytology and make sure that it's not one of those things I talked about that could mean that this is a malignant thing underlying it. But otherwise, the reason you do a core biopsy is because it shows you the actual structure of the tissue, so you can distinguish between carcinoma in situ and invasive disease, as well as do molecular staining, molecular subtypes, and tissue staining. In terms of epidemiology and risk factors, like I think it's a waste of time to remember specific stats, but obviously breast cancer is important and it's common. In terms of risk factors, it's relevant to you because you need to ask this in your OSCE stations to try and stratify the likelihood of somebody having breast cancer. And when I'm not really good at remembering lists, so I try to remember why something is a risk factor rather than just remember the list of it. But I guess female sex and age is they kind of self-explanatory. Same with family history for genetic reasons. The reproductive stuff that you ask about, like menarche, age of menopause, and like the obstetric history, are important because basically the longer the estrogen exposure without having the protective effects of pregnancy, the higher risk of breast cancer. And the reason that's the case is because estrogen kind of works in a pro-proliferative way in breast tissue. So it's pro-oncogenic, and pregnancy for whatever reason induces changes in cells that protect against cancer. So the longer you have a higher level of estrogen unopposed by that pro-pregnancy effect, the higher the risk of breast cancer. Obesity is probably in there because of peripheral production of estrogen, which is higher in that case. And again, estrogen comes into the picture with medications. So the combined oral contraceptive pill, so it has to have estrogen in it basically, and hormone replacement therapy are risk factors. I don't think you need to know that much about pathology. Basically, like most breast cancer that we deal with is invasive ductal carcinoma, and there's nothing specific about that. That's like the general stream of management applies to that type of breast cancer. Obviously, you can go into more detail in terms of like receptor positive status, and that influences the treatment decisions that we can use, which I'll talk about later. But I don't think you need to remember like luminal subtypes and all that kind of crap. But there's a few things to point out here that might be useful. So DCIS, the important thing is that it has a high risk of transformation compared to the lobular in situ subtype. So it tends to be treated. The problem with lobular carcinoma in situ is that it doesn't really calcify, so it's actually hard to pick up in the first place. So even though it can be treated more leniently or conservatively with close surveillance, it's actually harder to pick up. And as I mentioned, for lobular carcinoma, the specific thing is that it can be multicentric and bilateral. So we do MRI to characterize the extent. So investigation and staging, I guess the way it comes to you, whether it's through screening or through a breast symptom, you need to get the diagnosis using the triple test. And once it's diagnosed, you perform staging investigations as you would for any other malignancy. That includes blood tests, and it includes imaging to look for metastatic disease, which is generally a CT of the chest, abdomen, and pelvis. Can also include a whole body bone scan. We don't usually add brain onto that unless they have neurological symptoms or signs, so a headache or specific focal neurology. You stage it using the TNM system, which again, don't bother learning the specifics of. You just need to know that it's based on tumor size, the number of lymph nodes involved, and whether or not there's any distant metastases. I just thought I'd go briefly through the definitions of these different surgical options, because sometimes there's confusion about the terms. So wide local excision is the same thing as a lumpectomy. Basically, it's used for tumors where you can do like an excision of the whole thing with a nice 1 centimeter margin without making too much of a cosmetic difference to the breast, or if the patient doesn't mind the cosmetic appearance, then you can just do that successfully with those margins. Mastectomy is removal of the breast. You'd think that total mastectomy would be like the most extensive version of it, but it's actually the least radical. So you have sparing of lymph nodes and muscle in a total, and basically it just gets more and more radical from there, depending on how many lymph nodes you take, how many muscles and musculoskeletal tissues you take. The muscle that I'm referring to in this slide is pectoralis minor. Sentinel node biopsy is used to prevent unnecessary axillary node clearance. Because when you become a junior doctor, you realize that one of the bane of your existence is like patients that have lymphedema, and it makes it really difficult to get vascular access later. And there's obviously a whole bunch of complications for the patient in terms of discomfort in their arm, pain that's associated with lymphedema from axillary node clearance in breast cancer. So if we can avoid it, we can. Basically, the way they do it is during the surgery, they'll sort of inject radioactive isotope around the area where the tumor is, and then basically use a radiation detector, this is the gamma probe, to identify the nodes that drains to. They will sample 2 or 3 of them and send them off to pathology. And in doing this, we can probably save about 80% of patients that have a sentinel node biopsy from going on to have an axillary node clearance. Obviously, if there's tumor in those nodes, then they need to have clearance of some of their axillary nodes. Just in brief outline, these are the adjuvant therapies. So there's hormone options for cancers that are expressing estrogen or progesterone receptors. The main thing I think that's you can get caught up on predominantly in MCQs is which age groups these are used on. So obviously in premenopausal women, the ovaries are more important for producing the hormones. So ovarian ablation is only going to be useful in that population. Whereas the aromatase inhibitors, for example, which reduce peripheral estrogen production, is going to be more important in postmenopausal women because that's where they're getting most of their estrogen from. Herceptin is a monoclonal antibody that blocks HER2, which is a growth factor. So that's how that works. Radiotherapy and chemotherapy in breast cancer are pretty much used exactly how they are in every other type of malignancy. So the principle is if you can't get rid of all the tumor locally, then radiotherapy will be of benefit. So, you couldn't get good margins, or there's local invasion into structures that you can't easily remove surgically. Chemotherapy is used in younger patients because we want to be slightly more aggressive in that age group, but otherwise it's used in patients that have evidence of the tumour spreading systemically, because that's where chemotherapy is useful. So if the nodes are positive or they've got distant metastatic disease, that's when you think about using chemotherapy. And really, like, the principles of using these are more important than trying to remember exactly the criteria for using them, because even in clinical practice, it's kind of a decision that's made on a case-by-case basis in an MDT setting. So that's really important to mention if it's ever come up as part of an OSCE station, is that the decision for treatment is made collaboratively between the surgeons, the oncologists, pathologists, and radiologists. A few other things about breast cancer that I thought were useful, just to wrap it up. Obviously, metastatic disease is like the most important factor for prognosis, but otherwise it's lymph node involvement. There is a tumor marker for the breast, which is cancer antigen 15.3, but it's not that sensitive or specific. But I guess if you obtain a baseline, you can look at trends as part of your follow-up. Generally, there's only good evidence for follow-up up to 5 years, although some patients choose to be followed up closely beyond that. Obviously, at the start, you would check more frequently. So it's clinical examination like every 3 months for the first year. Then you can change to 6 monthly and then annually after a couple of years. So that's breast. We'll go on to benign thyroid disease next. I'm only going to talk about one developmental thyroid condition because it's pretty classic in surgical stuff, is thyroglossal duct cyst. The reason it occurs is because the thyroid develops from an area at the base of the tongue called the foramen cecum and then migrates down to its position in the neck. And in doing so, the tract that it leaves can sometimes develop swellings within it. And that's known as a thyroglossal duct cyst. So the classic thing about it on exam is that it moves with the tongue. So with tongue protrusion or with swallowing, because your tongue moves during swallowing. So it's essentially a clinical diagnosis because those are very characteristic features. And you manage it by removing the whole tract surgically. This is a summary of diffuse thyroid enlargement or diffuse thyroid swellings, because really there's a whole bunch of different causes of thyroid swelling, which can be either of these conditions, or it could be secondary to inflammatory thyroid disease, which we will talk about, or it can be due to things like endemic goiter. But a lot of the other conditions we don't ever really see in Australia, but we do see both of these. So I think a lot of people separate, simple colloidal goiter and multinodular goiter and toxic multinodular goiter, but really they're all part of the same spectrum. So essentially, it's a really long-term process where you start off with just general enlargement of the thyroid gland, it becomes more nodular, eventually multinodular goiter. Later on, it becomes hypothyroid, so it becomes toxic, and eventually it could sort of burn itself out and become hypothyroid. So the important thing to note there is because it's sort of a long-term evolutionary process, the patients are usually euthyroid initially, and they only become hypothyroid in that condition later in the disease course. This is opposed to Graves' disease, which is the other main cause of diffuse thyroid enlargement, which is autoimmune condition. So it tends to occur in people in which autoimmune disease occurs, which is in young adults, young middle-aged adults, and they're hypothyroid from the start. The Graves' disease also has some specific clinical signs. So it's got its eye signs, protrusion, ophthalmoplegia, chemosis, etc., pretibial myxedema, and thyroid bruit. Surgery is pretty much always indicated for the former condition, whereas Graves has some alternative options. which I'll talk about. Don't think you need to know too much about any of these, but there's a few characteristic things, especially about carbimazole. Not good in pregnancy due to risks of congenital malformations. And it's got a few side effects, agranulocytosis and hematotoxicity. The other option is propylthiouracil, and it used to be that was your alternative that you could use in pregnancy, but that's also been flagged now by like the TGA as contraindicated as well. So that's become a tricky area of management now. Don't forget that you can treat the tremor and a lot of the like sympathetic activation aspects of thyroid disease. So you can put patients on a beta blocker, which is usually propranolol, to help with that. If medical management fails, then you can try radioactive ablation. You want to avoid that if you're pregnant because you'll give radioactivity to the baby, and it doesn't work so well in patients with eye disease. So surgery is indicated if the above fails for eye disease, or in cases where you need to get control of symptoms quickly because the others don't. Radioactive ablation and medical management take a long time. They take months to control the disease. So thyroidectomy, there's just a few things to know about it. The patient should be euthyroid beforehand. So they still get treated with anti-thyroid drugs if you can. And you can give a course of iodine beforehand, which helps reduce, help the patient helps keep the patient euthyroid, but also reduces vascularity of the gland, which helps during surgery. The most common thing I've ever seen asked about in exams regarding a post-op complication of thyroidectomy is hemorrhage into the neck. So if you're a junior doctor on cover and you're looking after breast endocrine patients post-thyroidectomy, if they've got obstructive symptoms related to their airway and a big hematoma in front of their neck post-thyroidectomy, then basically you need to release the pressure on that and get help from a senior as soon as you can, because they'll need to go back to theatre. But if you have to cut the sutures to release the pressure from the hematoma, then that's what you have to do. The laryngeal nerves, both the superior branch of the external and recurrent, run next to the thyroid glands. They can be injured during surgery. Hypoparathyroidism can occur because the parathyroid glands are in close relation to the thyroid. And you can precipitate a thyroid storm if the patient's not euthyroid during the operation. And the treatment for that is steroids, beta blockers, and iodine, which is usually potassium iodine. The inflammatory thyroid diseases, there's only 3 that you might come across. The most important one to know about is Hashimoto's, and it's got its antibodies that you can order. It can be hyperthyroid initially, but will eventually become hypothyroid. De Quervain's is like a post-viral phenomenon that fixes itself. Rydell's thyroiditis is only relevant because it's a differential for anaplastic carcinoma, but it's very rare, and it's only seen in association with other fibrosing conditions. The other thing that you might come across is solitary thyroid nodules. So people might feel a thyroid nodule or they feel a lump in their neck, and you might think that's a solitary thyroid nodule. And so the way that you usually work up a lump that you think is in the thyroid is first to do thyroid function tests, because that's going to guide further management. If TFTs are abnormal, then that's the pathway you go down to do a nuclear medicine scan. If the patient's euthyroid, which is going to be most cases, then they get an ultrasound. If there's obstructive symptoms and like a large mass there, then that's more of an emergency and just get a CT neck. Ultrasound that you perform for euthyroid patients is then reporting using the TIRADS criteria, or at least that's what we do here in Adelaide. If it meets the criteria for biopsy, then you do an FNA, and then it's reported based on the Bethesda classification, which guides your management. You might be wondering, what's the benefit of doing an FNA? Why do you do FNA in this pathway and not a core biopsy? Probably more than just because the needle's too big. I mean, if you ever seen a core needle, core biopsy needle. Like you'd be pretty brave to be doing that around this area in the neck with the structures that are around there. So it's a little bit safer. The reason is that the thyroid gland itself is quite vascular. So sometimes we do core biopsies in the neck of lymph glands, but we don't tend to do them of the thyroid gland. The only downside of that is that there's one type of thyroid tumor that can't be sort of differentiated. You can't differentiate between the benign and the malignant form of it, and that's the follicular neoplasm. So you need actual structural tissue in order to distinguish between a follicular adenoma and a follicular carcinoma. So if it looks like it's a follicular neoplasm on the fine needle aspirate and you need to try and distinguish between the two, that's where we often do a hemithyroidectomy. So we take out just the thyroid, part of the thyroid that's implicated. We actually have a look at that tissue. If we see that it's a carcinoma, then we'll take out the rest of the thyroid gland. Otherwise, if it's just benign, we can get away with only taking out half the patient's thyroid, which means we don't have all the issues of having to replace the thyroid hormone, etc. So really, I've just got 1 or 2 slides on thyroid cancer. I think it's maybe useful to know mostly about papillary, but if you want to know just a couple of points, key points about most of the subtypes, then that's here. So papillary is the most common. It's usually in younger people, and it often presents first as a cervical lymphadenopathy. So it has a very high propensity to going to the lymph nodes in the neck, which, by the way, doesn't affect prognosis. And it's a TSH-dependent tumor, which means that after you remove it, it's really important to stay on top of your thyroid replacement, as keeping TSH low is going to help and prevent it from coming back. Follicular carcinoma, as we mentioned, requires the removal of tissue, so an actual excision in order to see whether it's carcinoma or adenoma. It responds well to radioactive iodine. Medullary carcinoma is important to know because it's the only familial one. So it's associated with the multiple endocrine neoplasia syndromes, which is the reason that we do some of these other tests, like PTH for parathyroid, catecholamines or metanephrines to look for pheochromocytoma, RET gene testing. RET gene is implicated in these syndromes. And the reason we do a calcitonin level is because medullary carcinoma comes from the parafollicular C cells, which secrete calcitonin. So the useful thing about that is that calcitonin can therefore act as a tumor marker in medullary carcinoma. Fortunately, it doesn't respond as well to radioactive iodine. And the final one is anaplastic carcinoma, which tends to occur more in elderly people. It's an aggressive tumor that basically invades everything in the neck. So because it's so aggressive and can metastasize early as well, we'll often do a PET scan as part of the workup for that. And definitely if they have local obstructive symptoms, then they should have a CT scan of the neck. So in terms of how we manage these, surgery obviously is the mainstay, as it is for pretty much all malignancy if you can. If it's a small tumor, you can maybe get away with just removing half of the thyroid, unless there's risk factors for it being in other places. If it's big, if there's evidence of it spreading beyond the thyroid on imaging or there's metastasis, then pretty much always total thyroidectomy. Radioactive iodine is often used after the surgery to clear up any residual tumor. So it has particular benefit for those which are large in size, that are multifocal or residual, or if there's nodal or distal metastases. Radiotherapy and chemo really aren't used that much for thyroid cancer. They sometimes are sort of if everything else fails as salvage therapy, but not so successful. Follow-up is basically clinical exam, neck ultrasound, TSH levels, and thyroglobulin levels. So like if you don't have a thyroid gland, you shouldn't be producing thyroglobulin. So that's kind of a nice marker for whether or not you've grown some abnormal thyroid tissue somewhere. And you have close monitoring for the first couple of years. But a lot of thyroid cancers have pretty good prognosis and are well treated, particularly papillary carcinoma subtype. All right, hyperparathyroidism. Not going to talk too much about the medical aspects of this, but the general classification is primary, secondary, and tertiary, where primary has an inappropriate PTH level, so you're secreting PTH from somewhere, basically, and it's usually because of a parathyroid adenoma. Secondary hyperparathyroidism is because of some other disease process somewhere else. It's almost always CKD that we see that in. And the mechanism is basically you can't excrete phosphate, and that results in increased PTH secretion in a physiological way. Really the only definitive treatment for that is to fix the underlying disease, which in most cases will be a renal transplant. But a lot of patients who have this won't be eligible for surgery, whether or not that's removal of parathyroids or a renal transplant. And so we can treat it conservatively, I guess, or just manage it by giving calcium or phosphate binders. Tertiary hyperparathyroidism is basically where you have persistent hyperparathyroidism despite attempted definitive treatment for the secondary type. So for example, you've given them a renal transplant, but you still have hyperparathyroidism. Usually fixes itself. But if not, they will have surgery to remove part or all of the parathyroid glands. So for primary hyperparathyroidism, which is the main area in which breast and endocrine will be involved, it's usually because of a parathyroid adenoma. It's usually found asymptomatically based on hypercalcemia, so whether or not they have symptoms of hypercalcemia. Most of the time, high calcium is detected incidentally on bloods, done for other reasons. But if it is found because of a symptomatic presentation, it's usually because of renal stones. You investigate further for a few reasons. And it's primarily to localize what the cause is. So, I mean, you'll do some blood tests to confirm that it's primary hyperparathyroidism. And then you look at bone turnover and try and see whether the patient has osteoporosis, because as we'll see in a second, that's an indication for surgery. But the key investigations are trying, in terms of guiding what type of surgery you would provide, would be an ultrasound and a type of nuclear medicine scan, which are designed to try and figure out whether or not it's one little gland that's implicated in causing this problem, or whether it's multiple glands. So when you'd offer surgery, if you have hypercalcemia that you're worried about, if the patient's had implications on their bone density, if there's renal complications, if they're young, or if it's symptomatic in any way. So you can either do open surgery or minimally invasive surgery, which is usually designed to just take out the one problematic gland if you can. So it needs to be very obvious on the imaging investigations that you did that particular parathyroid gland is causing the problem for you to go down that route. Otherwise, it needs to be a much more extensive bilateral neck exploration, and either a subtotal, which means removing 3.5 of the glands, or a total removal and then implanting one of the glands somewhere else in the body where it's easier to access if there's any problems with it later. Complications are pretty much the same as mentioned for thyroidectomy. There's a unique thing called hungry bone syndrome, where for some reason the bones take up all this calcium and phosphate a couple of days post-operatively. You basically just manage it by replacing the electrolytes. All right, adrenal tumors. There's not too much I've got to say about this. Basically, the main context you'd see it in is incidentalomas, which is where, for a different reason, you're performing a CT scan, but you've incidentally found these adrenal tumors. And so what are you going to do about them? Well, firstly, they're very, very common. So like I reckon almost 1 in 2, 1 in 3 scans that are done especially on elderly patients, will show bulky adrenals or an adrenal gland lesion. If you think that you need to work it up, the first thing you do is hormonal testing to see whether it's the functional tumor or not. You pretty much never biopsy these, and certainly not if it's a pheochromocytoma. If it's a functioning tumor, then it depends on exactly what type it is that guides the surgical management. If it's non-functioning, then management is guided based on sort of risk of it being a primary like carcinoma of the adrenal gland. And it basically has a lower risk of that being the case if it's less than 5 centimeters. So if it's beyond that size, or if it's growing on surveillance, then you take it out. So I'm not going to go through the medical aspects of each of these conditions, but where they are caused by a adrenal tumor, there are possibilities of performing surgery to remove the tumor or the adrenal gland or both adrenal glands. For Conn syndrome, which is primary hyperaldosteronism, usually surgery is reserved for unilateral disease, and there are medical options such as giving spironolactone for bilateral disease. For Cushing's syndrome, where it's caused by an adrenal tumor, surgery is done even if it's bilateral. Pheochromocytomas have some specific surgical considerations, and if you're ever on a breast endocrine term, it would be really cool if you could see a pheochromocytoma removal. Ideally, it's a laparoscopic resection, but it can be open if the tumor is large. Preoperatively, we give them an alpha blocker, which is titrated until the patient becomes symptomatic. So we don't want them to have a postural drop, but we kind of titrate it up to that point. And sometimes the beta blocker is also given in the last few days prior to surgery. It needs very close monitoring during the operation. So it's very intensive from an anesthetic perspective. And the patients have very high risk of post-op hypotension. So they often have to go to ICU for monitoring intensive fluid status and fluid bolusing, as well as inotropic support if that's required. All right, that's pretty much all I had to talk about today. I thought I'd just briefly go through what are the common OSCE stations that you get in breast endocrine surgery, which is basically just either a breast history or exam related to a lump, or a thyroid examination in patients with hyper or hypothyroid symptoms. So I haven't really gone through specifically what you need to do, but because I think you would have learned about that in clinical skills beforehand. But I think just remember that if most of the time in these stems, the patient comes to you with a lump. So just remember that you're going down the triple test pathway, not the screening pathway for these patients. And I think some that they could potentially ask about would be breast screening counseling specifically. So knowing a little bit about the current program, as well as the process of risk stratifying them, including taking a history for all the risk factors, would be part of that. And sometimes it's relevant to stations that present with a neck lump. Previously, they've usually asked about like Virchow's nodes in neck, which takes you down a different pathway. But if it's sort of other forms of cervical lymphadenopathy in higher levels in the neck, then papillary carcinoma, especially young patients, is probably the most common differential for an isolated cervical lymphadenopathy in that setting. So it's good to know about that, and it would be good to ask about thyroid stuff or examine the thyroid gland if it was a physical examination station. I think that's pretty much it, unless anybody had any questions about any of that.